So I've been tasked over the next 20 minutes to discuss with you the diagnosis and management of common dermatologic problems in our IBD patients. As an outline of where we'll go, I'll first discuss specific extraintestinal manifestations, Pyoderma, gangrenosum, and Erythema, nodosum, and then speak on cutaneous manifestations of paradoxical inflammation, the psoriasiform skin eruptions that we're seeing with increased frequency, particularly on anti-TNF agents. And then touch on skin cancer, both non-melanoma and melanoma, which are also adverse effects of therapies. I will do so by illustrating a series of cases. So this is the first case, a 37-year-old African-American female with severe inflammatory colonic Crohn's disease. She'd been maintained on methotrexate, and she presented with severe rectal pain and pus-like drainage. And she had this lesion. And so this is an extraintestinal manifestation of IBD, and when you look at the prevalence, as you can see here, arthritis is the most common, and in each extraintestinal manifestation seems to be somewhat more common in Crohn's rather than UC. But when you focus on the specific cutaneous ones, erythema nodosum and pyoderma, these seem to be somewhat more evenly distributed. And interestingly, I often, in my mind, associate these extraintestinal manifestations with disease activity. And often that is the case for arthritis, uveitis. But as you can see by this slide, with each of these extraintestinal manifestations, there's also a sizable proportion that occur in patients without active luminal or GI inflammation. And so these manifestations must also be considered in those individuals. And when you look by disease location, interestingly, nearly across the board of various extraintestinal manifestations, including the cutaneous manifestations, you see that there's a higher prevalence of these manifestations in individuals with colonic inflammation, and also those with small bowel and large bowel. So these are groups that seem to have a particularly increased risk. With Pyoderma gangrenosum, it often begins with a sterile pustule or a papule that rapidly breaks down to form a burrowing, painful ulcer. It often has a characteristic, sharply defined violaceous border and a necrotic base. It's often on the legs. Another common place that we see it in inflammatory bowel disease is peristomally. Obviously, this young lady had it perianally. When you look at the prevalence in IBD populations, in one tertiary care center population, approximately 2%, again, most commonly leg, followed by peristomal, and we see some of these same risk factors for development of pyoderma, including active bowel inflammation and that colonic involvement in Crohn's disease, or extensive colitis in UC. And as you'll see with many of these manifestations, seem to be more common among women as compared to men. When you think about therapeutic options, much of the data for therapeutic options of pyoderma are at the level of case series or case reports. We often will use high-dose oral or intralesional prednisone. I'll often do steroid injections into the lateral border of these lesions. Immunomodulators, dapsone, although caution if G6PD deficiency. Numerous other therapies have been reported, but potentially the treatment of choice now is anti-TNF agents. The reason is that we actually have randomized controlled trial data on the use of infliximab for the treatment of pyoderma. In this study, as you can see here, it was a group of patients with pyoderma, many of whom did have Crohn's disease or ulcerative colitis, but others without IBD. And they were treated with either infliximab or placebo at week 0. They had assessment at week 2. At that point, the lesions were measured to look at improvement. And then all of the patients rolled over to infliximab treatment. And as you can see here, at week 2, among patients on infliximab, there was a 46% rate of improvement as compared to 6% amongst placebo. When you then looked at week 6, once individuals had been rolled over to active therapy, as you can see by this slide, those with a shorter duration of pyoderma prior to initiating therapy actually had a greater percentage improvement as compared to those with longer duration. So tackling these lesions earlier in its course may have added benefit. A second case of an extraintestinal cutaneous manifestation, 33-year-old female with a history of UC. She had pancolitis, and she was maintained on 5-ASA, and she had new onset painful lesions on her lower extremities. She'd had no change in her bowel habits. She had had 1 to 2 bowel movements per day without blood. So often, again, these manifestations can occur in the absence of clinical luminal disease activity. And this is an example of the lesion, clearly erythema nodosum, an acute tender eruption of erythematous plaques and nodules, and it's usually on the extensor surfaces of lower limbs, as you can see here. There are known clinical factors, and again, you're going to see a similar theme: female gender, colonic disease, those with prior IBD surgery, and those who have other non-cutaneous extraintestinal manifestations seem to be at a greater risk for developing erythema nodosum. And there are a number of IBD susceptibility genes that have been associated with erythema nodosum as well, so both clinical and genetic factors. When we think about treatment, the literature, often the older literature talks about bed rest. You can often see erythema nodosum even in pregnancy, and that seems to be one form of treatment. But most often, treatment with corticosteroids, dapsone, cyclosporin, or other disease-specific therapy to manage the underlying Crohn's disease or ulcerative colitis. There was a nice systematic review recently of anti-TNF use in extraintestinal manifestations. And as you can see here, for Pyoderma and also for erythema nodosum, which had similar rates, while the response in non-interventional studies has been reported to be quite high, 92 to 100%, when you look at the response in interventional studies, it's actually much lower. And so we don't always obtain complete control of these extraintestinal manifestations and sometimes need to move beyond anti-TNF. A third case, a 27-year-old female, and she'd had a history of colonic Crohn's disease, and she presented with a new onset, scaly and itchy rash behind her ears and scalp. She'd had no change in her bowel movement frequency, and she'd been maintained for some time on adalimumab at 40 milligrams every other week. And this is a picture of the rash that she presented with. And clearly this is a psoriasiform eruption, a psoriasis. It's non-contagious inflammatory systemic disorder. And in up to 10% of cases, it's associated with inflammatory conditions such as IBD. But psoriasis is also a paradoxical inflammation. As we've seen the use of anti-TNF agents and now other biologics increase dramatically over the past 2 decades, we're starting to see reports of emergence of psoriasis. This delay in the literature speaks to potentially these autoimmune pathologies occurring in tandem with biologics, suggests that there's a low incidence, or that potentially these reactions are associated with prolonged or cumulative doses of biologics. They're deemed paradoxical as that they occur in patients on biologics initiated with the intent to treat an inflammatory condition, such as RA or IBD. And so the prevalence of these anti-TNF-induced skin lesions has ranged in the literature from anywhere from 2 to 29%. The incidence is 5 per 100 person years. And importantly, these aren't limited to IBD. In patients with other autoimmune-mediated conditions, such as rheumatoid arthritis, we also see these psoriasiform eruptions. They can occur as early as 1 month into treatment, but more commonly occur during maintenance therapy, and interestingly often occur when the patient's luminal involvement of their inflammatory bowel disease is under control. The level of data we have on describing this phenomenon is at the level of retrospective cohort studies. This was a very nice study published just this year that looked at 917 patients with inflammatory bowel disease who were initiating anti-TNF therapy and followed them for a median time period of about 3.5 years. And they found the eruptions of these psoriasiform eruptions to be psoriasiform eczema, xerosis cutis, which is dry skin, palmoplantar pustulosis, psoriasis, and some other etiologies as well. And the lesions typically occurred in the flexural regions, the genitalia, or the scalp. When they looked at risk factors, they actually found a similar prevalence amongst men and women, unlike some of the other series, and amongst smokers and non-smokers. There wasn't much difference in those who developed a positive ANA, although it was slightly higher among those with these skin lesions. And I think importantly, they looked at median cumulative doses and trough levels of infliximab in patients with and without these skin lesions. And they actually found no statistically significant difference in trough levels of infliximab among patients that did develop these lesions as compared to those that did not. There did seem to be somewhat of a genetic tendency in that in a priori identified risk variants, those with higher numbers did seem to have a greater incidence of developing these skin lesions. And interestingly, there did seem to be an association with a specific IL-23 receptor gene. And so when you look at the literature of all of these series, these retrospective series that have been published, the factors that have been associated with an increased risk of these paradoxical psoriasis reactions include smoking, Crohn's disease as compared to ulcerative colitis, potentially higher doses of anti-TNF, although I just showed you data from the largest retrospective cohort study that did not see an association, higher BMI, and female gender. And the factors that seem to reduce this risk are having a concomitant immunomodulator and a diagnosis of ulcerative colitis as compared to Crohn's disease. And so when you think about treatment of these reactions, the majority are managed with conservative treatment. We use topical emollients, steroids, potentially systemic treatment, such as addition of an immunomodulator, and often the anti-TNF that they're on can be continued, and they have improvement of this psoriasiform eruption. This can occur in up to 89% in various cohorts. However, there is a segment of the population that cannot continue on the anti-TNF. And the most common reasons for discontinuation were often the location. So if the location was on the face or scalp in a very obvious location, that was difficult to have continue. Itching or pain, recurring symptoms, so that continual applications of topical agents are required. And often these patients can have associated arthralgias that can be debilitating as well. So in one series, after stopping the anti-TNF in a group of 28 patients who'd had these anti-TNF-induced skin lesions, 17 of 18 had resolution of symptoms over a period of 3 months. In severe cases, ustekinumab, obviously newly approved for the treatment of Crohn's disease, an IL-12/23 inhibitor, also approved for the treatment of psoriasis, has had efficacy and has high efficacy in various series. So when you think about how to manage this paradoxical response that, at least in my practice, I do feel I'm seeing with increased frequency, I first confirm the diagnosis, communicate with a dermatologist. Smoking cessation here, if we need one other reason to advise smoking cessation to our patients, here we have it, can be advised. Conventional treatments, topical steroids, emollients, as I mentioned, phototherapy, occlusive treatment, and consider addition of an immunomodulator as well, as that will often help to control the eruption. If you do have improvement, continue on the anti-TNF plus minus the immunomodulator. Whereas if you don't, the next question I ask myself is the TNF adequately managing their bowel inflammation? If the answer is yes, I can check a level and potentially try to dose reduce in the event that this may be a dose-related phenomenon, or consider an alternate TNF, recognizing that in some case series, up to 50% of individuals may recur with an alternate anti-TNF. And certainly, if the bowel inflammation is not fully controlled on the TNF, you could consider initiating ustekinumab, which may treat both the underlying psoriasiform eruption and the Crohn's disease. So I'd like to move on with one final case, a 42-year-old male with ileal stricturing Crohn's disease of 10 years duration. He had a prior ileocecal resection, and he's in clinical and endoscopic remission on azathioprine. And he presented with a scaly, red, non-painful rash on his nose. And this turned out to be a basal cell carcinoma. He'd thought it was just an irritation on his nose. And 1 in 5 Americans will actually develop skin cancer, and it accounts for 1/3 of all cancers in the US. And some of the main environmental risk factors include ultraviolet light, chemical exposures, and host risk factors, where the main risk factor clearly amongst our IBD population is immunosuppression. And when you look at the incidence of skin cancer in patients with inflammatory bowel disease, this is a study we did using a very large administrative claims database across the United States. As you can see here, take Crohn's disease, for example, the annual incidence of skin cancer per 100,000 is 764, as compared to 416 in a comparison cohort. So a markedly increased incidence. And then, when we actually drilled down and looked specifically at the medications these patients were on, we found that thiopurines drive this risk of non-melanoma skin cancer, as you can see here, with an odds ratio of 4.2 to 4.3 in both Crohn's disease and ulcerative colitis. There does seem to be potentially a mild to moderate increased risk with biologics, but some of that may actually be associated with concomitant thiopurine use. And methotrexate, which is also known to increase photosensitivity, while not statistically significant, may also be associated with an increased risk. And then we looked at actual specific combinations of therapies. And as you can see here, we're using patients with inflammatory bowel disease on no immunosuppression as the referent. Patients who are on thiopurines had an odds ratio of 4.4 for development of non-melanoma skin cancer. But when you were on a combined thiopurine and biologic, that odds ratio further increased to 6.75. And this was among a population of patients who had been on these therapies for at least a year with persistent use. And why do we think this happens? We have elucidated some of this mechanism in that azathioprine has been shown to selectively increase photosensitization of human skin to ultraviolet light. And it creates these 6-thioguanine photoproducts. And so sunlight induces this chronic oxidative stress and it increases the levels of oxidative DNA skin lesions. This photo is an example of photosensitivity testing, which we and others have done on these therapies, which shows that at a less light exposure to UVA light, patients will have more sensitivity when they're on azathioprine. So that seems to be the mechanism, potentially preventable, of developing non-melanoma skin cancer. Another form of skin cancer, which luckily my patient did not have, is melanoma. A much rarer incidence, but the rate is increasing, and it's tripled in Caucasians over the past 20 years. And immunosuppression is a known risk factor for melanoma as well. For example, transplant patients have a 3.4-fold increased risk of development of melanoma. So we did a study looking specifically at melanoma as well. And I want to point out that the absolute risk of melanoma is much lower than that of non-melanoma skin cancer. As compared to numbers in the 700s, we're now seeing numbers in the 60s. But as you can see, this risk is still elevated as compared to a comparison cohort of patients without Crohn's disease or ulcerative colitis. And so the incidence rate ratio for development of melanoma in a population of patients with Crohn's disease is 1.45. And so yet again, we looked specifically at medication use to determine what seemed to be driving this risk of melanoma. And as you can see here, using 5-ASA use as a comparator, biologic anti-TNF medications are associated with approximately a 1.9-fold increased odds of development of melanoma, whereas we did not see an increased odds with thiopurine use. And so while the thiopurines seem to drive the non-melanoma skin cancer risk, it's actually the anti-TNF medications that drive the melanoma risk. And so it may be also related to innate differences in underlying IBD immune dysfunction that can contribute. And unfortunately, we don't yet know the mechanism of action as to the increased risk associated with the anti-TNFs for melanoma, but that's an area that needs further investigation. But one thing we do know is, particularly with the data from azathioprine, is that if UVA photosensitivity is increasing this risk, then there's an opportunity for us with prevention. Recognizing this and recommending to our patients that they wear sunscreen, broad spectrum sunscreens that cover both UVA and UVB, since UVA light is the causative agent here, and that they reapply sunscreen. There's also potentially a role for secondary prevention. There's not a current recommendation for annual skin examination in IBD or in the general population. This is actually an I for the USPSTF, but this really should be considered. And soon to come out, ACG prevention guidelines will be helpful in steering us on recommendations for this. But certainly annual skin examinations are recommended in post-transplant patients on immunosuppression and should be considered in patients with inflammatory bowel disease on immunosuppression as well. And certainly any skin lesions suspicious for malignancy should be evaluated by a trained dermatologist. And so, in summary of the cases I presented in these dermatologic manifestations, case 1 was perianal pyoderma. She had been just on methotrexate, and I added an anti-TNF to her regimen based on our only available randomized controlled trial data, and performed intralesional steroid injections. She actually did well and did not require diversion, but that's something to consider given the location of her pyoderma. For case 2, with erythema nodosum, assessed for disease activity and used a corticosteroid taper to get that under control. For case 3, my patient with anti-TNF-induced psoriasis of the scalp, it was in a very difficult location in that it was very obvious. We tried many topical agents, corticosteroid solutions, UV light. We initially continued the anti-TNF as her bowel inflammation was under excellent control. She did not respond to addition of an immunomodulator, and she was therefore changed to ustekinumab. And I can report that her psoriasis has now resolved. Case 4 was evidence of a non-melanoma skin cancer. And so this gentleman went to a local resection with Mohs surgery. I'd emphasize prevention, sunscreen use. He's in a much increased surveillance with his dermatologist at this point. And I did continue his azathioprine as it had been very effective for him. But it is something that he's aware of the ongoing risk associated with continued sun exposure. And that concludes my presentation. Thank you.